Thanks very much for that kind introduction. My job here is to try and introduce you to the idea of dementia and Alzheimer's disease and the role that omega-3s might play. Now, first of all, I have to tell you that Alzheimer's disease isn't really a disease, and that may be a little bit difficult, so I'm going to just give you a little history first. Alzheimer's disease was a name coined by Emil Kraepelin at the turn of the 20th century to describe some findings that Alzheimer made in a single patient called Auguste Deter. Auguste D was nothing like the Alzheimer patients we see today. She was 51, she was paranoid, aggressive, psychotic, and mute. Not the sort of person we think of as having Alzheimer's disease. But he identified these miliary foci, which we now know to be made of amyloid protein, the abnormal protein, and we call them amyloid plaques. And it was thought for the first part of the 20th century that essentially Alzheimer's disease was a pre-senile dementia and pretty rare. But in the 1980s, genetic mutations were found in some familial cases of Alzheimer's disease. And the assumption was, because this amyloid had also been seen in senile dementia patients, that somehow the presence of amyloid was the cause of dementia in late-onset Alzheimer's disease, and we call that LOAD. And so that set in place this incredible search, for the holy grail of the Nobel Prize or the Mega Millions or whatever it was, to try and find this amyloid-removing treatment, the cure for Alzheimer's disease. And it even infected the G8 summit a few years ago, saying that we were going to cure Alzheimer's disease by 2025. Nonsense. What we diagnose in the clinic isn't the pathology of Alzheimer's disease. It's clinically called dementia. And what dementia is in fact an age-related end-stage organ failure, brain failure. And brain failure, like heart failure or kidney failure or liver failure or respiratory failure, will have many causal factors and will never have one simple cure. So AD, Alzheimer's disease, in a sense, is just a name for a kind of brain pathology that we find in some patients with dementia, and amyloid is one of the pathologies. Now, amyloid is a player. I'd rather not have a brain full of amyloid than one that was full of amyloid, but it's not the cause of Alzheimer's disease. And if there's one thing you just take away from this meeting, it is correlation does not imply causality, and this is the real bugbear of epidemiological research. Now, when I have sort of expanded this in medical meetings over the last 20 years, I've been rounded on by lots of people saying, well, you can't argue with the genetics. Alzheimer's disease is amyloid. The genetic causes of Alzheimer's disease all increase the production of A-beta, amyloid A-beta. And I say, well, look at the data, will you, for once, instead of looking at what you want to see. And if you look at the data, you will see that in 97% of Alzheimer's patients, no pathogenic mutation can be identified. And if we have a look at the genome-wide association studies that have occurred over the last sort of 10 years or so, what we find is that all of the AD genes, that's PS1, PS2, APP, even tau, all fall far below any kind of genome-wide significance. What those studies have uncovered were a number of susceptibility genes. These are genes that don't cause Alzheimer's disease dementia, but they actually make it more likely given other circumstances. And interestingly, none of these susceptibility genes, like APOJ, APOE, PICARM, SORL1, etc., none of them have anything to do with amyloid. What they have something to do with is transport of lipids, transport of proteins across membranes and maintaining the integrity of membranes, suggesting to me as a simple clinician that essentially what goes wrong in dementia is not the accumulation of amyloid, but it's the loss of function of the synaptic membranes. Remember, the membrane's the most important organelle in the body. It's what separates the nerve cells from each other, and it's outgrowths of membranes that cause the synapses, which allow information to pass from one nerve cell to the next across an intact membrane. And without an intact membrane, that doesn't happen. And without an intact membrane, our brains would just be a liter of soup. So the membrane is incredibly important, and that's confirmed too by pathological studies, like the medical research CFAS study, like the David Snowden's NUN study. What we see is that a third of patients with these pathological levels of amyloid were never demented in life. And 2/3 of those people who have dementia never have amyloid in their brain when you look at it. So amyloid is not the key. And yet, what has that led to in terms of, I'm sorry about this slide, but, well, I'm not sorry at all, or I wouldn't have put it there, would I? Essentially, this is looking at AD treatments over the last 10, 15 years that I've been involved in, and you can see that a number of drugs down here. These are the modes of action, and this is whether it satisfied the primary outcomes at phase 2 or phase 3, phase 2 being the sort of safety studies to see if you've got some sort of effect from the compound, phase 3, the large clinical trials that will lead to registration. And what we see is a lot of studies that have failed at phase 3. Not a problem. That's what phase 3 trials are for, to weed out the drugs that are really not going to produce any clinical benefit. What really pisses me off is essentially so many of them have failed already to meet their primary endpoints at phase 2. And our almost religious belief that if it treated amyloid, it must work. We just need more patients or different patients or people with blue hair or gray hair or whatever, instead of looking at the data and saying, no, it doesn't work. And we see all of these studies, the antibody studies and the various other anti-amyloid studies, which failed to show any benefit, we'll continue with. What we see working, the only treatments we have available are nothing to do with amyloid, but to do with neurotransmitters. And how do they work? They work by passing from one membrane to the next in a synapse. And the other things that have worked in phase 2 are also neurotransmitter-based treatments, like 5-HT6 antagonists, nicotine agonists, etc. I put in the bottom here a medical food, Suvinade, because although that isn't a drug and therefore doesn't have to satisfy phase 2, phase 3 regulation, it did show some positive effects in 2 studies, 12 weeks and 24. And I'll talk a bit more about that later. But just to get back to sort of finally nail this amyloid story, so you're very clear, essentially we did in Southampton the very first study of an anti-amyloid vaccine in human beings in the world. And we followed our patients up. And this is a histology slide. This is a slice of brain from a patient who was not in the trial. This is a control patient, and you can see the staining for amyloid. These brown plaques are very typical of the amyloid plaques we see in patients with Alzheimer's disease dementia. This patient died 4 months after the vaccination started of a ruptured aortic aneurysm, and you can see already at 4 months the plaques are starting to break up after vaccination. This patient died 20 months after the vaccination started, and you can see already the amyloid has been cleared from the parenchyma of the brain, and it's simply left around the blood vessel walls in the perivascular spaces, and that's how amyloid is drained out of the brain after vaccination. This patient died 5 years after vaccination, not a molecule of amyloid there at all. It's gone from the parenchyma, it's gone from the blood vessels, it's completely gone. The vaccination did exactly what it said on the can. It removed amyloid from the brain. But every single one of these patients died with the severest form of dementia, Braak stage 6. With a mini-mental state of 0, it made not one whit of difference to the course of the disease in these patients. And that's the elephant in the room I can't get past when we're talking about trying to find treatments. So we need to change our minds. Oops, wrong one. And we need to rethink what we're talking about when we're talking about Alzheimer's disease. And just to show I'm not a maverick, I mean, this is, the zeitgeist is there. Many people are saying the same thing. This is Francesca Mangilash from the Karolinska Institute, and she says, since a cure for dementia is not yet available, I would argue a simple cure will never be available, but finding an effective dementia strategy is essential for sustaining society in an aging world. And she says, as we all know, that as dementia, cardiovascular disease, stroke, and diabetes, all major public health issues, all share several risk factors. Surely, public health efforts promoting healthier lifestyles have the potential to enhance health status in advancing age. But where are we in terms of managing treatment? We're no further forward than when I started with the first clinical trials. We're no further forward. We have memantine, a glutamatergic drug, and the cholinesterase inhibitors. And the combination of memantine and cholinesterase inhibitor is the best treatment you can give to anyone who's got dementia. So you can take that as your second take-home message. You combine the two. And that's the best we've got, and it's all we've had for the last 10, 15 years. What is interesting to me, I won't go through that, but what's interesting to me is that there is a change. There is a change in the zeitgeist. Essentially, what we have seen over the last 10 years is a number of community wide initiatives looking really more at lifestyle change, concentrating on exercise, which we know is protective, and principally concentrating on diet, and that's where you come in. And one of those studies looking at lifestyle intervention was the Finnish geriatric study, the FINGER study. And the objective of this trial was to reduce cognitive impairment in an at-risk population. These were they weren't patients, they were people, older people, who had memory worries, memory concerns, but weren't diagnosed with dementia. And they entered this package of lifestyle interventions, which included diet, exercise, cognitive training, and monitoring and managing vascular risk. And what they showed in this study, after 2 years, was that the neuropsych test battery, the NTB-Z scores, in the intervention group were 25% higher than in the control group, who just had general advice on lifestyle. It didn't actually improve memory per se, but improved executive function, concentration, attention, and well-being. So simply by changing lifestyle, by modest changes in lifestyle, in fact, you could actually have an impact on the patient's cognitive outcomes. Oops. Now, if we just to sort of back that up, those patients were chosen through because they were at risk through the CADE at-risk profile, and the CADE is another interesting way of looking at things, because this is Mia Kivipelto from Karolinska, and she's been involved in this, and she's identified these sort of 7 different risk factors which can predict your risk of developing dementia in 20 years. And if you score highly on all of these, you have a 16% risk of becoming demented in 20 years. Now, the astute amongst you will notice that, of course, age is by far and away the trump card here. I mean, if you're 10, your 20-year risk of developing dementia is nil, isn't it? So it's, clearly, it's, you've got to be my age for these to count. But essentially, if you can, you clearly can't alter, you can't alter the top 3, then you're stuck with those. Well, I suppose I don't think it alters your genetics. But essentially, what you can do, very simply, is alter these. And this is where omega-3s come in. We're talking about cholesterol, we're talking about systolic BP, and we're talking about very modest changes, reducing BP under 140, getting your BMI under 30. I mean, it's not a major challenge. And if you can do that, what you will do is you will reduce your risk from 16% down to 2%. So you can have a major impact on your future risk of becoming demented just by managing a few simple cardiovascular risks and lifestyle management. Now, we know that diet is important. I mean, that's clear. The brain needs specific nutrients to build and maintain itself and its structure. And it's 60% fat, as you know, and the type of fat influences the physical properties of the cell membranes, the very important cell membranes. And we've all known that nutritional deficiencies are associated with impaired brain function. We know omega-3 fatty acids affect levels of mood, behavior, stress, depression, and dementia. That's all been shown. And we've known for centuries that vitamin B deficiency is linked to various neurological conditions and psychological disturbances. The need to supply specific nutrients to the brain, however, is actually increased when you start to develop neurological disease, and I'll explain to you why. And enzymatic reactions in the brain are very much controlled by local concentrations of substrates. So getting the substrates into the brain can make a difference to how those particular pathways, like the Kennedy pathway, work. Now, the problem we've had in trying to sell this is that all the studies of nutrients in dementia have failed. And when I started, we were doing studies with lecithin and choline, and of course you couldn't blind those studies because the patients all smelt of fish if they came through the door. But essentially, they were ineffective. And we look at these things that the omega-3 fatty acid studies didn't show rate of cognitive, slow the rate of cognitive or functional decline, did not delay the rate of cognitive decline. We see B vitamins did not slow cognitive decline, did not support the hypothesis that homocysteine lowering with B vitamins improves cognitive performance. Vitamin E is slightly mixed. I mean, some of the studies saying it didn't support the hypothesis of homocysteine lowering with B vitamins improves cognition. There was some slowed functional decline in this study, no benefits in this study, and worsening in this study. And we know the high doses of vitamin E can be toxic, of course, cardiovascularly. Vitamin D, no good. Ginkgo biloba, no good, as we know. So why is that? If we need these nutrients so much to repair the damaged and the oxidized membrane, why are they not working? Well, what has come up in the last 10 years is a lot of epidemiological data showing an association between dietary patterns. And it seems it's dietary patterns, it's combinations that seem to make the difference. And we've seen that regular intake of fish, Mediterranean diet, and even adherence to nutritional recommendations in middle-aged adults can impact on their future memory performance. But as you've just heard, life is not a randomized controlled trial. And in nutrition, it's particularly difficult because it's really difficult. As soon as you start to alter someone's nutrition, they change the way they live. And they start altering their behavior, altering their nutrition. And so they often yield very mixed results. But what these data suggest is that supplementation with combinations of nutrients is probably more effective than targeting one single nutrient to improve cognitive performance. And the reason is that if we are trying to, one of the effects of having this amyloid and the inflammation and all these other things going on in the brain is oxidation of the membrane. You need to replace the membrane at a time when you need more and more spines and synapses to be formed. So replacing membrane is very crucial. And to do that, you have to make phosphatidylcholine. And to do that, you need the Kennedy pathway. And just at a time when you need more and more of these nutrients to create more and more membrane, repair the synapses, we know that you have problems. Because in older people with Alzheimer's disease, they have reduced plasma levels of vitamin B12, vitamin C, vitamin E. This increases homocysteine, which in turn reduces CSF and brain levels of omega-3 fatty acids. There's an age-related reduction in the uptake of choline by the brain. You can give older people and younger people the same amount of choline. They'll have the same blood levels and totally different brain levels. There's reduced synthesis of uridine in older people. You don't take uridine in the diet. You normally make it from breaking down RNA. But in older people, that's less efficient. And what is key to this Kennedy pathway is that every single one of these substrates is rate limiting. So if you leave one of them out, you won't drive the pathway. You can drive it, you can increase it 100% if you provide enough substrates. But if you're only providing one, or you're not providing all of them, you will not drive it. And so that suggests that it is this idea that we need to have combinations of nutrients. You need to feed all of the substrates for the pathway to make it work. Now, one thing that struck me in the last couple of years was Mark Mapstone's study. Now, what he did was he'd identified a whole panel of 10 plasma lipids. Most of these are phospholipids, which all reflected cell membrane integrity, getting back to the membrane again. And what he said was, if you have low levels of these 10 plasma lipids, he can predict your conversion from cognitively healthy to MCI, Alzheimer's disease, dementia, in 2 to 3 years with greater than 90% accuracy. Now that was fascinating. It got widely publicized. And at the same time, I was doing some studies with a compound called Suvinade. Now, many of you will know nutrition, you'll know Suvinade. And Suvinade includes this package called Forticin Connect, which includes DHA and phospholipids. What they showed in this study that we did was over 6 months, patients on Suvinade were statistically better on the NTB, on their memory measures after 24 weeks compared to the control group. But what was interesting was, as I said, that this includes a number of phospholipids. And unbeknownst to me or to Mark Mapston or anyone else, they had actually measured the levels of those phospholipids. And not by chance, but fortunately, 7 of the ones they actually measured were 7 of the ones in Mark Mapstone's array of 10. And what they saw in the Suvinade trial was that 5 of those 7 were increased in the patients taking Suvinade, suggesting that you can clearly influence the lipid levels by nutritional input, and that can actually have an effect on cognitive function. So I think this was a very nice sort of fortuitous combination. So if we're trying to assess the evidence that we've got so far, it is quite difficult. It's tempting to go straight to randomized controlled trials, and I did a lecture called The Cult of the Randomized Controlled Trial some years ago. I think we've got slightly obsessed by randomized controlled trials to the point of excluding good evidence, as you heard from the previous speaker. The idea is that only the randomized controlled trial tells you the truth. Well, that's not true. There are other ways. We have to, of course, look at preclinical studies to consider the mode of action of the things we're trying to measure. And we have to look at trends and doses and comparators and intakes in a whole range of different research methodologies. Epidemiology, prospective cohorts, observational studies are very important, and population-based studies are very important. Randomized controlled trials are useful. I mean, and they do give you some very important information, but you have to interpret the results with real caution when you're doing nutritional studies, because nutritional studies don't easily lend themselves to the RCT format. So where is there any good evidence? Well, the good evidence is there that you need certain kinds of nutrition for optimal brain health. And there's good evidence for vitamin E, there's good evidence for DHA, for folate, B12, and the ratio of saturated to non-saturated fats. And if we look at specific problems in dementia, in Alzheimer's disease dementia, neuroinflammation is probably the key. And this is probably why people get worse. Why someone with dementia gets worse when they get a urine infection. It's not because the germs from the bladder get into the brain, it's because of the peripheral response to cytokines that gets into the brain. So neuroinflammation is very important. Glucose dysregulation, homocysteine, and neuronal loss. All of these things can be addressed by nutrition. I'm thinking here particularly, of course, of omega-3 fatty acids. Now, the advice we get on nutrition is appalling in terms of dementia. I mean, the Royal College of Psychiatrists in the UK, is very happy to recommend omega-3s for bipolar, schizophrenia, to recommend different ketogenic diets and whatever, but they make no comment at all about, in terms of nutritional advice for Alzheimer's disease or dementia. And yet we're quite happy to accept nutritional advice on any other organ failure. We're talking about heart failure, we're talking about kidney failure, we're talking about liver failure. Nutrition advice abounds. Brain failure, nothing as yet. So we need to change that. We need to change perceptions, not just from the public, but from the professions as well. And so where are we going in the future? Well, essentially, dietary correction earlier in the disease course, I think, is key. Not just single supplemented nutrients. I think nutrient combinations are much preferable to these single nutrient supplements. Dietary pattern adoption instead of single food recommendations, I think, seem to be the key. The Mediterranean diet, the olive oil diet, the nut diet, these sorts of things. I think we need to develop better trials that work for nutritional studies rather than being tied to the randomized controlled trial. And this nutrition in combination with lifestyle change, I think is incredibly important. So we need to include exercise programs. We need to include risk factor management, cardiovascular risk factor management. And the other important thing just to remember is that in people who already have a brain failure, already have a deteriorating brain, are probably going to need higher levels of these substrates than you would recommend as a prevention. Okay, well, if you have been, thanks for listening.